welcome to the first webinar in the two-part series on COVID-19 for SBCC Practitioners. These webinars are organized by members of the 2020 International SBCC Summit Secretariat from Johns Hopkins Center for Communication Programs, UNICEF, Soul City Institute for Social Justice, Social Change Factory, the American University of Beirut Center for Health Practice, Puntos de Encuentro, and Digital Green. I'm so glad that you're all able to join us, and we look forward to hearing from our two presenters today. My name is Elizabeth Sorlomichos, and I am the moderator for today's webinar. We are hosting this webinar since we would have been in Marrakesh this week. We would have been still at the beginning of an exciting week of learning and innovation in the world of social and behavior change. Even though we cannot be together in person, we are happy that we can still meet online this week for the two engaging webinars. I see loads and loads of people are arriving from all over the world. It's really exciting to see everybody gathering together, and we're happy that even in the context of this emergency situation, you're able to find the time to join us today. So thank you and welcome. Before we get started, I'd like to share a few housekeeping announcements. All of our participants are on mute, so please submit your questions at any time through the chat box in the lower right-hand side of your screen. Then we can review those questions during the question and answer period. Please be sure to also disable your video, as it may affect the bandwidth for some of the participants. Also, please be advised that we are recording this session and that both the presentation and the recording will be made available on the Summit YouTube channel following today's session. We will also be engaging in an ongoing discussion on Springboard and on the CI network, and those discussions will be set up, are set up already, and will be starting immediately following today's session. Our format for today's webinar is in two consecutive presentations with a small amount of time for questions at the end of both presentations. Again, please feel free to type any questions you may have along the way into our chat box so that we can address those during the question and answer period. We may not be able to answer all your questions today, but please send them anyway. We want to hear from you. What we aren't able to discuss today, we will try to revisit in our next webinar, which is happening this Thursday. So without further ado, we will begin. I would like to first present to you Catherine Bertram. She will be presenting on risk communication and community engagement in disease outbreaks, specifically looking at COVID-19. Catherine is a senior program officer at Johns Hopkins Center for Communication Programs. She is presently working as the Social and Behavior Change Risk Communication and Community Engagement Advisor on the OFDA-funded READY initiative. Catherine has been providing social and behavior change and advocacy support to public health emergencies, malaria, child survival, and nutrition programs for the last 9 years. She provided technical SBC support to teams in Liberia, Guinea, and Sierra Leone during the 2013-2016 Ebola outbreak in the Mano River region. She's been conducting exploratory missions and contributing to the SBC assessments and recommendations during that time. She provided technical SBC expertise and capacity building support to UNICEF C4D Sierra Leone, serving on the social mobilization pillar and developing standard operating procedures for integrating social mobilization throughout the emergency response. Catherine also led the development of an emergency communication implementation kit, also known as an iKit, as well as an Ebola communication implementation kit under the USAID-funded Health Communication Capacity Collaborative, HC3. Without further ado, I will hand over to Catherine.
Great. Thank you so much for that, Elizabeth. And hello to everyone. Um, yeah, just as Elizabeth said, my name's Catherine Bertram, and I'm a Senior Social Behavior Change Advisor with Johns Hopkins Center for Communication Programs. I'm currently working on the OFDA-funded READY initiative. And just another quick note on the READY initiative. It is a consortium of partners. It's led by Save the Children. And the consortium members on that project include Johns Hopkins Center for Communication Programs, Johns Hopkins Center for Humanitarian Health, Echo Health Alliance, UK Med, and Mercy Malaysia. And the goal of the READY initiative is to augment capacity of NGOs and humanitarian actors to respond to outbreaks of epidemic or pandemic proportion and call for a broader humanitarian response. And we do that by looking at strengthening coordination, operations, and technical capacity. And so I'm going to go ahead and start. If we can go to the next slide, please. And so forgive me because I'm used to presenting to some humanitarian agencies that are less versed in social behavior change concepts. And so I just want to start with a few basic definitions so we're all on the same page. And so what is social behavior change? And so the simple definition is that it is the intentional process that seeks to understand and facilitate change in behavior, social norms, and the contexts that drive them. Next slide, please. And so I think a lot of us are familiar with this socio-ecological model. And so we look at what is happening around individuals as much as what the individual thinks and feels themselves. And so we look at those different layers of individual behavior and then influencing behaviors or influencing drivers at the family, peer, community, and social structure levels. And so if we can go to the next slide, please. And so when we unpack the behavioral drivers at these multiple levels, at individual, psychological, social, and structural, we understand why people do, we understand that why people do what they do is extremely complex. And importantly, people don't just consider the pros and cons to making a rational decision on the best path of action. And so providing them with the right information rarely automatically translates to that logical choice. Which is not to say that which is not to undercut the value of providing that critical information in emergencies, but we just need to consider as well that just simply providing messages alone is not going to be as effective. And so if we can go to the next slide, please. And so in an emergency, this is especially the case. We need to have an understanding of the elements that influence a person's decisions and actions. And we usually start by understanding their knowledge, attitudes, and practices in an emergency regarding a disease and the preventative actions. We need to understand that gap between what people know and what they actually do. And if we can go to the next slide, please. We need to understand people's perception of risk in an outbreak context. So not only how susceptible they think they are of getting the disease, but also their perceptions of how likely they are of transmitting the disease to others. So for example, there was a study done during the H1N1 outbreak in 2009 in one country that found that most people surveyed felt they were likely at risk of getting the disease, but much fewer believed that they were a risk to others. So what would be the implications of this in our behavior change program? We need to understand these perceptions. Next slide, please. Whether or not a person feels stigma due to the disease is another issue that can lead people to not seek care or treatment or not comply with certain practices, such as isolating the sick within households. We have seen how Asians and the Chinese have been stigmatized in the COVID-19 pandemic. Communities that are seeing surges in cases can also be stigmatized. Refugee populations or foreigners can be labeled as super spreaders and cannot only stigmatize, but can cause escalating tensions. Next slide, please. And then what are the social norms? What do we think other people think about the behaviors? And what do we see them actually doing? And how accepted do we feel within that context? Next slide, please. How accessible and trusted are the health services? What impact would COVID-19 have on these systems? And how would that be reflected in our own behaviors and what we can feasibly do? Next slide. In times of emergencies and stress, people tend to hold on to cultural and religious traditions and rituals even more. But some of these cultural and religious practices can accelerate transmission of the disease. Next slide, please. And our built environment can make adhering to recommendations such as social distancing and isolating sick family members in the house extremely challenging. Next slide, please. Linking back to what was said earlier, a lot of countries have already ceased religious gatherings, put restrictions on those, because they've led to some already big increases in cases in their countries. But religious leaders are hugely influential in many areas. So how can we leverage them for behavior change? Some messages have been incorporated, for example, into Friday prayer calls over loudspeakers, for example. Next slide, please. And so I want to also start with a definition of risk communication as well. So the way that the WHO defines risk communication is the exchange of real-time information, advice and opinions between experts, people facing threats to their health, economic or social well-being. The purpose is to enable people at risk to take informed decisions, decisions to mitigate the threat of that risk, to protect themselves and their loved ones. Next slide, please. And so there were some famous studies done in the 70s and 80s on the perception of threat and the perception of risk. Next slide, please. And so the bottom line from those studies is that we are less concerned about the health risks that are voluntary, that we choose to take, that are familiar, that are controllable, controlled by self, so we have some control over those threats, that are fair, so they're not singling out individuals or groups, that are endemic rather than epidemic and sudden, and not particularly fatal. Next slide, please. Conversely, we are more concerned about those health risks that are involuntary, they're imposed on us, they're less familiar to us. We don't feel as much in control over the situation. Again, they're epidemic and so sudden, and they're grouped by time and location and tend to be more fatal. Next slide, please. And so what do we do with this information? So the extended parallel process model states that for individuals to take protective actions, they must feel threatened by the consequences of a behavior and feel able to act to avoid that threat and believe that the action is effective. And so, for example, when you have situations where the perception of threat tends to be really high, but the perception of efficacy or people's confidence in the ability to act on any protective actions to mitigate that threat is low, then what you might have are people who are controlling their fear rather than controlling the danger. And that can lead to a rejection of those public health messages. Conversely, if they're not feeling the threat as well, they can disregard those messages outright. And so what we want to get to is a balance of that perceived threat and perceived efficacy, so that people are controlling the danger rather than disregarding or controlling the fear. Next slide, please. Can you click ahead? Yes, perfect. And so this is just one example. It was actually a Facebook post from a friend of mine who's a software engineer, and I thought it was an example of that balance between perceived threat and efficacy. So I reflected on whether she reflected on, can this happen to me? Is it bad? Is there an effective solution? And am I able to do that solution? And if we can go to the next slide, please. However, people who are struggling even more to meet their basic needs, and more so due to the COVID-19 pandemic, may ignore prevention measures or seek to bypass imposed mobility restrictions. Next slide, please. And so some of the things that we can do in situations like that, we can start to think about accelerating the communication on disease transmission, on the signs and symptoms, and those prevention behaviors that people can take. We can consider emphasizing the severity and susceptibility of the disease, using role models and testimonials about the dangers and effectiveness of the solutions. We can demonstrate those positive behaviors and how effective they can be. What we don't want to do, however, is to incite fear. So with trusted role models and influential leaders, we can consider emphasizing social responsibility as well, and the ability of people to do something positive for their families, for their neighbors, their communities, and the likely consequences of non-compliance. Next slide, please. Can you click a couple of times? Thanks. And so, you know, I just wanted to reflect on this just for a bit. During the 2014-2016 Ebola virus, something that we definitely don't want to repeat again is during that time, especially in the very early stages, social behavior change, risk communication, community engagement was not as prioritized in those early stages. And so what we had happening and what we were seeing is that response organizations were really trying to increase that level of threat so that people would take preventative actions. But what they were doing was putting out messages that was really only increasing the fear. So putting out those messages around how Ebola kills, there's no cure, there's no treatment, there's no vaccine, without really, while also not really putting out those really effective messages around what people can do, some of the preventive actions that they can take and how they can feel more control of the situation. And so what you really had was a lot of fear, hiding, people not wanting to go to the Ebola treatment centers, the Ebola treatment units. And that was really leading to an increased level of transmission and deaths. And this was a real turning point, I think, for risk communication and community engagement in disease outbreaks. Next slide, please. And so organizations really reflected on how they do business, including the WHO, who has developed this integrated model for emergency risk communication. And so importantly, and I won't go through everything here, but we really need risk communication systems, so those resources and those structures. Importantly, we need intense coordination so that partners, not only partners on the ground who are doing risk communication and community engagement, are coordinating with each other so that there's not mixed messages, people aren't scrambling on the ground, but that there's a higher strength and coordination among the risk communication, community engagement pillars and the other response areas. As well, particularly in emergencies, response teams really want to get messages out, but information that does not take into account people's perceptions and how they see illness and death, for example. This is really an important piece of information that needs to be better incorporated. And so that dynamic listening, understanding what those rumors are, addressing those perceptions, those rumors and behavioral risks, and doing so through participatory community engagement also became more of a priority. Next slide, please. So I just want to touch a little bit more on community engagement, and as well I'll do so in a bit in the context of social distancing. Next, please. Okay, so as we know, community engagement is a process of working collaboratively with groups of people affiliated by geographic proximity or special interests with respect to issues affecting their well-being. And I just want to state here, maybe emphasize that when we talk about communities, it's not just communities, geographic proximity, because there are some communities, there are some areas like conflict zones, for example, that may not have a structured community with formal community leaders in the way that we think about this in other contexts. And so communities can also be those special interest areas, those women's groups, those religious leaders, and so on. And so please click. But importantly, in the environment of in the situation of social distancing, we should also think about how we engage communities a little differently. And so we're not having the same types of group community dialogues that we will do in the past. So we need to think a little bit more innovatively of how we can use more interactive community radio, for example, mobile platforms, other ways of engagement that won't put ourselves at risk, that won't put our beneficiaries at risk, because we want to, of course, do no harm. Next slide, please. But importantly, communities must be at the heart of any public health intervention, especially in emergencies, and that should not change. Next slide, please. Next slide, please. So these quality standards and indicators for community engagement were developed by a partner-driven process. It was led by UNICEF C4D. And so I just wanted to go over this quickly because I think even in this time where we're practicing social distancing, these standards should still apply, and that we should still be thinking about a more participatory approach, even if we're doing that a little bit differently. And using that two-way communication, again, even if we need to do that a bit differently, using a different technologies and mobile systems. Importantly, we need to be inclusive so that we're reaching those marginalized and vulnerable populations, that our response is localized and it's adaptable to the local context. And importantly, we're building on that local capacity. Next, please. So again, what does this mean in those challenging environments during a COVID-19 pandemic when social distancing is a critical measure? And there's a lot of challenges, and there are a lot of areas we need to think about in this context. Next slide, please. Some of you may be familiar with the non-pharmaceutical interventions at this point. And so WHO updated these non-pharmaceutical interventions for mitigating the risk and impact of epidemic and pandemic influenza in 2019, so fairly recently. And so looking at lots and lots of research, they've really come to making these recommendations based on severity, what those non-pharmaceutical interventions are. And if we can go to the next slide, please. And so we can see based on those non-pharmaceutical interventions, the types of risk communication messages for COVID-19 that are being recommended in terms of course, the signs and symptoms, prevention of spread, these hand hygiene, respiratory hygiene, avoiding touching our face, rational use of face masks, cleaning surfaces, home care for individuals, so isolating those individuals in a separate, well-ventilated room. Again, wearing face masks for people who are sick. Social distancing, 2 meters of space in public places. Staying informed, avoiding public exposure, preparing the home and family. And so if we can go to the next slide, please. But again, consider those communities with overcrowded housing and large families, inadequate or limited access to health facilities, inadequate access to soap, water, supplies like face masks for people who are ill with COVID-19, hand sanitizers, resistance to staying home from work if it means loss of needed pay, cultural and social norms related to communal eating, religious, spiritual practices of communal prayer services as examples. And these are just some of the major challenges. Go ahead to the next slide. And then considering what those impacts could potentially be in those our low income settings, and particularly where there are humanitarian crises, because potentially there can be higher transmissibility due to those larger household sizes, due to the intense social mixing between the young and elderly, overcrowding in urban slums and displaced people's camps. Again, inadequate water and sanitation, soap, and those cultural and faith practices. There could potentially be more severe disease due to comorbidities in these low-income settings or areas of humanitarian crises, particularly as people may not have adequate treatment for their underlying diseases like hypertension, diabetes, for undernutrition, and TB, HIV, and so on. So potentially there could be a higher case fatality due to a lack of intensive care capacity, especially outside large cities. And then considering the disrupted care for health problems other than COVID-19. There's some potentially these risk factors could be counterbalanced by younger age distributions. Next slide, please. But there are other additional risk communication and community engagement considerations. And so that fear, helplessness, denial people may feel, there could be some complacency in some areas, particularly, as I mentioned, if some people are already dealing with other problems around hunger issues and lack of food, other diseases. Lack of trust in health systems, in response agencies, in the government, isolation and some of the mental health and psychosocial support needs, quarantines, and so restriction of movement and how that impacts even us as NGOs to work in communities. Death and grievance in this situation, and we all have been keeping up with the news, but people will not be able to breathe in the way that they're used to, particularly if we're used to large mass gatherings for funerals. And how can we work with communities around messaging for those areas? Again, our overwhelmed health systems and the lack of supplies, vulnerable populations, particularly, those migrant populations, refugees, IDPs, for example. The fact that vaccines won't be available until some time for the majority of the population. Rumors and misinformation, we all have seen this, and how we can address some of those rumors and information, as well as stigma, and I think we've all seen this as well. And then conflict, the potential for conflict due to many of these different circumstances, for example. Go on to the next slide. And so, how can we address some of these areas, and how can we do it in a participatory way? Some of the things that we've been thinking about at the Global Risk Communication and Community Engagement Working Group, which is led by WHO, UNICEF, and IFRC, is can we start looking at mapping communication opportunities along a transmission pathway? And so, for example, with community level people like community leaders and medical teams, can we start identifying those transmission pathways at the household level, at the community level, at the health post level? And then map how key influencers can play a role in the various points along that pathway, and what the entry points for communication are. Next slide, please. And so importantly, using those trusted influencers to engage. So if we know what those major opportunities are along that transmission pathway, who are those trusted influencers who can engage? So, in some cases it may be youth leaders, in some cases it may be spiritual community or traditional cultural leaders. Community groups, women's groups, educational networks, and so on. And so identifying who those trusted networks and influencers are will be really critical. And we all have those networks. So can we go on to the next slide, please? And so we've identified some basic actions for community engagement around COVID-19. So it's important to engage, of course, before, during, and after the pandemic. We need to focus on the adoption based on community feedback, behavioral and social evidence, and aligned with the country context. And so I just want to sort of highlight this area of community feedback. That will be really critical. In camps, there are ways to do that with feedback boxes where people can put their feedback into those boxes. We can collect community concerns in all different types of ways, using mobile phones, using surveys, and so on. But this will be really important to do consistently, so that we make sure that we understand what people are listening to, what rumors they're listening to, what their concerns are, what their perceptions are, and adapt accordingly. Go ahead to the next slide. And then when we're designing our social behavior change, risk communication, community engagement activities, considering those important theories that we all know in terms of using some of those observational learning, so that people can designing in a way such that people are seeing the behavior in practice and seeing the benefits derived, so that they're building that self-efficacy. using those prominent members of society to influence so that diffusion of innovation can happen a little bit more rapidly, so that people can see how simple is this behavior? Does it work for me? Can I see it? Can I try it? Next slide, please. And then again, critically looking at those communication channels. And there are different channels that we can use for different purposes. And so in this time of social distancing, we may need to rely a little bit more heavily on those mass media and mixed media. And again, but still doing community engagement, just thinking about it a little bit differently. And then thinking a little bit more innovatively about some of those mobile and digital and social media platforms that we can use. And so there's some effort that's being put into this now. There's a lot of thinking. I think, of course, I know the Center for Communications Breakthrough Action Program is also thinking about this very seriously and putting out some guidance. The Risk Communication Community Engagement Working Group at the global level, and I'm sure also at regional and country level, are also thinking very seriously about this as well, and already using different platforms to engage, to do rapid assessment surveys, perception surveys, and so on. Go on to the next slide, please. But importantly, we need to understand, how are people already communicating and adapting? So we don't need to necessarily introduce a lot of new innovations when we can really understand how people are already communicating with each other. And so having a good understanding of that so that we can leverage those systems will be really important and just should not be ignored. Go on to the next slide. And so, for example, like in Yemen, there's a community engagement working group, and a lot of, there's a lot of, I think, data that we can find within different individual country contexts, where we can see what the most effective channels that are being most used among our beneficiaries, what the beneficiaries are seeing as the most trusted communication channels, and so on, and how can we leverage those. So understanding that data is also going to be key. Go on to the next one, please. And then importantly, I just want to maybe end by, we talked a lot about messages and communication channels and engaging communities, but we can also think a little bit more innovatively as well. And so, I found, so that this, for example, was an intervention that was done in Bangladesh around constructing hand washing stations near latrines. And so the hand washing, use of those hand washing stations with soap increased 18% after those hand washing stations were put next to the latrines. However, after the footpaths were put in place, connecting the latrines to the hand washing stations, 58% of children washed hands after leaving that latrine. And then another nudge was put in, so the footprints and the handprints increased that percentage to 68%. And then 2 weeks after the intervention, 74% were washing hands with soap and water. And so just to say that, we can also think about our structure, the structural element as well, and how can we think innovatively around changing behaviors. We can think about that in terms of, like I said, those camp-like settings and those crowded housings. How can we think innovatively in terms of working with people to, maybe demarcate an area within a home or within a camp-like setting, using chalk or using paint, so that you can create a little barrier between the rest of the family and, for example, someone who may be sick with COVID-19. And so can we think a little bit more about some of those structural innovations as well? Maybe just one other example, in the Ebola outbreak in DRC, a lot of feedback was coming back to IFRC about rumors that were circulating around body bags not being used for people, but they were being used for rocks, that people were putting rocks in them because they were using they were harvesting organs from, from the bodies and so on. And so there were rumors circulating around this. Instead of, putting out messages to combat those rumors, or instead of just kind of increasing messaging, they redesigned those body bags so that people can actually see that there are bodies in the bags and not just rocks. And so maybe I just want to end on that note that we can think a little bit innovatively as well in terms of our behavior change interventions. Thank you very much for your time.
Thank you, Catherine. I hope I am on. Thanks. I really appreciate the presentation, Catherine. And it is now my pleasure to introduce to you Ketan Chitnis, who will be giving our second presentation. Ketan is currently the Chief of Communication for Development, C4D, at UNICEF in Mozambique, where he manages UNICEF's work across social and behavior change communication in health, nutrition, WASH, child and social protection, as well as external communication and public advocacy for children's rights. Previously, Ketan has worked on providing global and in-country support to risk communication and community engagement across several public health outbreaks, such as H5N1 and H1N1, Ebola, Zika, and cholera. And he is now engaged in the COVID-19 response in Mozambique. His specialization is in public health communication and community empowerment in primary healthcare, and he holds a doctoral degree from Ohio University in this field. Ketan's going to speak to us about the implications and considerations for RCCE on physical distancing, quarantine, and isolation during COVID-19. Thank you and welcome, Ketan.
Thanks, Elizabeth. Can you move to the next slide, please? Right, so I'm going to speak briefly, good afternoon, good morning, everybody. I'll speak briefly about some of the lessons we have learned from the previous outbreaks and then what it specifically means for us in terms of considerations, drawing upon some of the literature that's already available, as well as a lot of the unknowns that are there, so putting out some considerations for our work in this field. So to the right in the screen, you see the usual risk communication, community engagement, or a strategic communication for behavior change planning cycle, which starts with collecting data, looking at both qualitative, quantitative kind of understanding of risk perceptions, knowledge about disease transmission, ability to practice behaviors. We talked about it in Catherine's presentation about risk perceptions and self-efficacy, for instance. So those are the kind of indicators we would be interested in. Then we are looking at setting objectives across preventing the outbreak, mitigating its impact, mitigating the secondary impact of the outbreak, and ensuring that we are addressing rumors and misinformation and not causing panic and fear. So there will be a set of communication objectives that we'll be looking at, which we can then address based on priority groups that we will identify, of course, which would be all the public, but specifically the vulnerable groups and the more at-risk population, and that's what I will speak mostly about today. And then there'll be a range of strategies that we can think about, including a range of communication platforms that we can use and those we cannot use given the certain kind of the conditionalities of the outbreak and the contagion, given that it's spread very rapidly between human to human. So we'll have to limit some kind of group communication activities, for instance. Monitoring, and particularly kind of behavioral monitoring issues, but also feedback from the communities is increasingly critical, and it's a central part of all of the national plans for RCCE related to any outbreak, including COVID-19, because that would be the way for us to actually address concerns of communities when it comes to actually enforcing or promoting some of the behaviors which will lead to addressing the prevention of the disease and hoping to an end in transmission. Having all these kind of both kind of evidence-based principles and a practice-driven model of doing a well-coordinated communication plan supported at the national level in view of the national response plans. I mean, some of the key lessons that we've learned from some of these other outbreaks has always been the tension between, the recommended top-down type of practices, behaviors around prevention of infections or mitigating impact. But then what do we do in terms of, superlaying those within the context of countries, communities, socio-political context, and so on. So we always talk about this kind of an expression in public health communication or in public health more broadly about putting the public at the core in public health interventions. And I think this becomes even more critical as we are looking at this pandemic. The second thing is, I think, some of the lessons with regards to, we've seen this in the past from SARS, for instance. Short-term behavior change is feasible because people see that it's a disease which is spreading widely across their communities, within countries, across nations, and some of the visual behaviors are relatively easy to adopt, and people who have means to adopt them do adopt them, knowing that those are for a short period of time. And I will dwell on this kind of short period of time a couple of times during the presentation. So those are also teachable moments where I think it's possible to get people to practice behaviors. But at the same time, we also know that there are always groups which will not be able to practice behaviors even during these times. And those could be people with disabilities, there could be certain ethnic or other minorities that are not usually trusting the government or other sources that are engaging with them, could be displaced population and refugees which are hard to reach, and so on. So there are always issues with regards to how do we manage. It's not a kind of a one-fit strategy which is going to work for everybody within the country or even a community. The other point in terms of lessons is, I think, the nimbleness. So in most public health responses, there will be, of course, proven non-medical or interventions which would be promoted through different communication strategies. But depending on the phase of the epidemic and depending on how it spreads within the communities, there are also certain behaviors which would be prioritized over others. So if, for instance, right now, if it's hygiene practices, respiratory practices, and say physical distancing, but then there's also at the same time, we know it's very important to isolate, test, and treat. So when we're looking at some of the contact tracing related community engagement interventions, we will need to be a bit more nimble, and we'll have to engage in those practices as we go forward. So there are these kind of different, and there will be many other lessons that we'll need to look into from all these other disease outbreaks that can help us kind of inform how to implement some of these national communication plans. Next slide, please. I briefly touched about it, but essentially we are looking at the public in these public health measures, particularly for this presentation, and looking at considerations that we could look into as we design the communication response. So we know at this moment what we really want is that people broadly, everybody, those particularly more at risk, but broadly speaking, in most countries, almost all the population needs to practice respiratory and hand hygiene behaviors. And that comes with its own kind of challenges, particularly we know with regards to hand washing, for instance, because access to water is probably a challenge for about 30% of the world's population. So we have to then come up with kind of locally contextual ways of using ash and so on to promote hand hygiene, for instance. So again, a relatively simple measure, but putting the public at the core of it in hand washing, we know, and there are other considerations that we need to look at as well. Similarly, we are looking at now practicing and recommendations more and more around physical distancing that come in the form of avoid crowded areas, making It's possible to probably have markets which are spread out at distances. People have to still go to hospitals. So how do you ensure that there is physical distance within kind of healthcare settings? So there are nuances when you're looking at physical distancing measures, which would be promoted and then practiced by communities as well. There's also kind of ways in which the public needs to adapt to physical distancing as certain public places close down. Schools, for instance, work from home. Everybody's doing that who can manage that. Public transportation is closed. So what does that mean when it comes to providing means for kind of community transport for certain emergencies or for essential services? So again, it's one thing to promote a particular behavior, but the uptake of it will be determined by all these other considerations. Contact tracing, I briefly spoke about it. It's also one key measure when it comes to a public health intervention, and that's needed before things get into testing and isolation and treatment, which is where the other more kind of medical side of the response takes over rather than the communication side. This presentation, I'll speak not in too much depth, but a little bit also about what it comes to people, those who are suspected or are sick themselves already. So quarantine measures for asymptomatic contacts, I think, is an issue, which is about essentially staying at home for a couple of weeks. And then isolation, particularly for mild symptoms at home, again, which has its own implication when it comes to isolating somebody who's not well or showing symptoms. At the same time, a caregiver who needs to be careful and other members in the household who need to be distant or physically distant from that person. So there are a lot of these public health considerations which we need to look into. Next slide, please. So physical distancing, I mean, just as a in a nutshell, those of you who are working on COVID-19 will already know this, or for some of the other diseases that we've looked into these issues around influenza, SARS, and so on. The recommendation is to have at least 1 meter. It's 1 to 2 meters, I think, distance. So those are things which I think which are to be promoted, not just in homes, but also we need to consider, I think, shelters where probably, people who are migrants or refugees or displaced population will be put in. Isolation wards for people who are, sick or showing symptoms, but they're not necessarily in their homes, but they're kept in certain areas because the numbers are large. So there'll be a range of issues that we need to take into consideration, in addition to, of course, avoiding any mass gatherings, which is, religious gatherings, cultural gatherings, sports, you name it. These enforcements, are being done in terms of either recommendations which are voluntary, and then there's also recommendations around voluntary or mandatory closure of non-essential establishments, as sports places, places of worship, and so on, restaurants, and so on. And then there are the more kind of the more severe measures when it comes to locking down any movement, for instance, except for essential services like food and medicine. There are curfews, we know, in several countries that have also been implemented, during certain hours. So these all make it quite challenging from the communication standpoint to actually ensure that there is understanding and over a period of time, of course, also, for lack of a better word, compliance with these measures. So the challenges related to these, when we look at it from a more vulnerable at-risk population, comes down to several issues. Urban slums, for instance, also certain kind of large chunks of low middle income countries, maybe even rural areas, so to speak. There could be challenges with regards to just limited space, so it's hard to really isolate somebody or quarantine at home, or and keep a distance. There's also a need, if you don't have access to certain things like water, how do we take that into account? The governments can probably think of trucking services for water during certain emergency periods for in certain communities, but these things will have to be taken into account as these measures get implemented and communicated. There's also issues with regards to I think, socioeconomic factors. So social protection measures are already being thought of and probably being implemented in some countries, where blanket cash vouchers would be given, because it's hard for people who are not able to earn a daily wage to be able to survive if there is long periods of of lockdowns or when you're not supposed to physically move for work. Similarly, we also need to think about, I think, others kind of populations with special needs, particularly people with disabilities and the caregivers who are working or who are with these people and children with disabilities. Given it's hard to be physically distant when you're a primary care provider. And similarly, there are also psychosocial and mental health needs which happen as a result of being, due to lack of social cohesion, as well as, among children, for instance, because suddenly routines are disrupted and many other factors. So, I mean, these are, again, things which we need to consider before or as part of our communication planning around these measures. Next slide, please. On quarantine and isolation, as I said, I mean, I haven't got too many considerations for this in this presentation, but just for us to collectively think about it, I mean, there is the whole issue of voluntary or enforced stay at home for 2 weeks when it comes to quarantining, especially if somebody's had a exposure to someone who is coming from a high-risk country with COVID-19 or actually has COVID-19. And then when it comes to isolation, it's somebody who has symptoms. Some of the communication challenges when it comes to enforcing some of these issues, which we have seen in, during Ebola, for instance. Also, I think some of the other public health interventions is stigmatization, and that happens as a result of either quarantined or being sick, or somebody when you're looking after somebody who is sick. So that becomes a big challenge. We've also seen quite a few reports of health workers being stigmatized, for instance, because they are looking after, patients of COVID-19. And that's, I think, kind of falls within this whole issue of addressing stigma. There's also ensuring that, there isn't quarantining being done necessarily with labeling, which again contributes to stigmatization and identification of people. And we've seen in some countries that there are stamps put on people's hands and forehands. And so these are issues which I think we need to really consider from a communication standpoint. And also I think overall space, once again, like, physical distance within a home. Similarly for quarantine isolation, I think it's something which we really need to take into account, given the crowded density that's there in several countries, particularly in urban slums, but also in rural areas. Next slide, please. So some considerations, right? So I think there are some positives that are coming out. And so when we are communicating and engaging the public, across these measures on distancing and quarantine, we've seen already, I think, Catherine mentioned in the last slide, the use of nudges. So we've seen kind of visualizing behaviors. You may have seen, I think, in several countries, they're putting square boxes or circles in public places where people are supposed to go out to purchase essential items, but are supposed to maintain a physical distance. You've also seen that in the context of schools, where the schools are still open. Instead of having 3 children on a bench, you mark out 2 spots and you have 1 child in a bench. If you're, of course, you need to be able to provide additional space for all the other students. So there is some form of visualization, which also, helps to be a trigger for practicing behaviors. Being in media and communication, I think, role modeling is a perfect example, as we are having stories through entertainment media on entertainment education or other kind of formats, where one is looking at role modeling, a range of preventive behaviors around prevention of COVID-19, and physical distancing could be one of those, which also can take into account, I think, aspects related to inclusion and addressing the stigma issues which we talked about. I already talked also earlier about this issue on, certainly a difficult behavior to practice, physical distancing, but it's and it's a frequent everyday behavior one will have to do, but it's for a short period of time. So this is something which we can leverage in terms of efficacy issues, the models that we have. So if the risk perception is high and the efficacy of able to practice that behavior is there, knowing that it's not necessarily a lifelong practice that one needs to take on, and there aren't any other kind of socioeconomic considerations, then it's still feasible for us to use some of those cues in the communication approaches that we'll use. In terms of addressing stigma discrimination, I think this has again been used in other conditions or other disease outbreak responses. Those who survive after being isolated, or those who are in quarantine and test negative, as well as those who actually survive going to hospitals and coming out, celebrating those survivors, I think, and in some ways welcoming them back into the communities is certainly a proven way of addressing stigma and ensuring there's more inclusive practices. And then there are also, of course, multiple ways in which we can still engage communities, including children, to express themselves and to be able to take on new behaviors. So within the confines of, particularly for those who have access to some technology-based medium, or those who can be reached through loudspeakers or some kind of very traditional forms, through community means, I think can still look at exercising, I think, how people are able to manage and cope with adopting these behaviors in order to prevent transmission. Next slide, please. When it comes to low resource settings, I mean, I think there are some specific considerations we need to look into. And here, I think it's particularly about kind of low middle income countries, areas which are resource poor, geographically maybe isolated. So even when we're saying that essential, let's say, commodities are available, such as food and medicine and water, if people need to travel long distances to markets, that's something that need to be considered. So, as communicators, we can talk about what needs to be done, but it needs to be reinforced through advocacy and other measures whereby, markets could be brought closer to people, for instance. And again, it's to be done in for a short period of time, so it's feasible to be done. That minimizes people unnecessarily moving out of their houses and fearing spread of the disease or getting infected. Similarly, I think local transport, it's common in several parts of the world to have motorbikes, for instance, or very cramped kind of minivans. Clearly, those will be kind of hotspots for rapid transmission of coronavirus. So how do we then consider, maybe some community means, for transportation, which are monitored through community groups. It's possible to do that. Again, these have been done in some of the primary healthcare kind of settings when it comes to transporting patients to hospitals, for instance. So we'll have to think about that, but of course, within the context of maintaining, minimum distance and some kind of hygiene practices. Religious places, I think, and places of worship, I think, are another ones where we usually engage with community leaders and faith leaders to actually go out and engage with kind of large masses. Now, while these might be stopped or are already being stopped, one could still consider using, radio broadcasts or loudspeakers so that the trusted communicators can still engage with their congregations and their, community members in terms of promoting all these behaviors that are needed to stop transmission. Next slide, please. I think there's also considerations that we need to give with regards to mitigating the secondary impact of COVID. So one is, of course, getting sick from coronavirus, avoiding that, if one gets tested and exposed, get tested, isolate, get treated, and so on. But there's also, I think, all the other sectors which are going to be impacted. So some of the key ones that we've been looking at, I think, is schools. So when schools are open and when schools are closed, what do we do? So when schools are open, it's I think a good moment to have kind of child-friendly health education, prevention kind of messages or education given to kids across all age groups. So again, developing some of these child-friendly materials becomes important for this disease. There are then measures which will have to be practiced in schools when it comes to where usually kids congregate. Those places will have to be somehow redefined in the context of when schools are open. And when schools are closed, I think it poses far more problems, particularly when it comes to aspects regarding how do you ensure distance learning or learning continues through technology or other means. when people already are having challenges, accessing regular school. So I think that's something for us to consider. I don't have necessarily very concrete examples of what's being done over there. We should certainly look into aspects related to displaced population, migrants, refugees. So again, there are ways in which one can, proactively engage with them. We saw some pictures in Catherine's presentation about people already communicating, between Jordan and Syria, for instance, across those borders. So people may have technology which needs to be then tapped into for prevention of COVID, and then specific measures need to be put in place, such as providing temporary shelter, engaging with this population to ensure that there is risk reduction measures also within that context. A big thing for UNICEF that we are looking into right now, again, this was the lessons from Ebola and some other outbreaks. There tends to be more violence against children and women, gender-based violence and so on at homes, as the usual social life gets disrupted. Men and children and young people remain at home. So I think here, I think empowering health workers to maybe, if they are the ones who are in the community still, then to be able to somehow identify vulnerable cases and then link them back to community referral systems for protection, as well as having, continuing communication and media efforts on social behavior change communication to address issues related to violence and violence prevention particularly. The other group is elderly and people with disabilities, not as one group, but separate groups. And I got dropped off. I'm back.
There you are. Great.
Sorry, I think it was timed. I had 15 minutes. So maybe I think there's the last slide, if you don't mind. Yeah, so implications, I think this is the last slide. I've just put down like 5 points here, particularly for our work across these measures on distance, social or physical distancing, quarantine, isolation, and also the other hygiene practices. So we all know about timely, accurate, transparent communication, which is critically important because if it's top down and imposed, it's not going to necessarily be taken up particularly by certain population groups. We know that. Two-way channels, particularly to build trust. Again, lessons from past across all outbreaks and other kind of health communication interventions. Looking at certain rights being suspended. I think that's part of WHO's, I think, work with regards to IHR. So human rights, of course, are paramount, but in certain circumstances when these lockdowns happen, I think certain rights are suspended. But again, we need to look at it. What does it mean in terms of leaving behind certain groups because of these kind of harsh measures? We look into different models of communication and theories which can guide us, particularly I think in this case, aspects of risk perception, aspects of what people can do themselves, as well as I think issues, with regards to nudges and other things that can help us quickly identify new behaviors and practice them for the short time at least. And while we look at community engagement as something which is done, with really physically close communities, I think there are lessons, and I think there's also recommendations about doing distant community engagement, technology clearly, but also maybe other means of relying on in low resource settings, and maybe as long as health workers and outreach volunteers are active, kind of using them, ensuring that they're protected, but still trying to engage communities and listen to them as much as possible. So I'll stop here, Elizabeth, and I'll pass it on to you.
Thank you, Ketan, and thank you, Catherine. both of you have given us excellent presentations. I have noted that we have run quite short on time, but perhaps we'll have time for maybe one or two questions. I hope both Ketan and Catherine can hang around for, as I said, one or two questions. The first one I would like to pose is whether or not there are any insights on how to balance the use of stricter measures, but avoiding the use of violence. Just like Ebola, the burial process for COVID-19 positive patients could be facing resistance from families. I'm wondering if Catherine or Ketan would be in a position to provide some response to that one. Hoping our technology works and that they both are available to give us some response.
Sorry, Elizabeth, sorry, could you repeat the question? I didn't catch it.
Sure. The question was on the insights on how to balance the use of stricter measures, but avoiding the use of violence in terms of ensuring physical distancing. For example, with Ebola, the burial processes with COVID-19 positive patients might face some similar resistance among families.
Well, I think it's a very good question. I mean, I think one of the means is to really work with law enforcement, and I think training on communication skills as well as maybe some community engagement skills with law enforcement might be, or others that are used in terms of ensuring that these measures are implemented, or they're responsible for implementing those interventions, but are not necessarily taking, again, the public and the community points of view into account. I think is one way. And then the other is, again, this probably goes back, easier said than done, but building trust in the response systems with communities by, really regularly engaging.
Sorry, Ketan, I lost you again. Okay, well, I'm sorry that Ketan wasn't able to finish his answer, but I also recognize that we are basically out of time. But I am happy to let you know that Thursday's webinar will be the opportunity for us to take up the rest of the excellent questions that had come up in the chat box. And we will hopefully also have an opportunity for Ketan and Catherine to give the really key takeaway messages from their presentations, as I think that would be a helpful addition to the webinar. But just to remind you, you can continue to submit questions today via the summit organizers information email, as well as engage in the conversation on Springboard and on the CI network. I believe that the links for those things are all being put in the chat box now. And that also shows you the links on that slide. So if you haven't done so already, submit additional questions. We will close the questioning by the end of today. And also just a reminder that the webinar was recorded and the recording will be posted on the Summit YouTube channel, as well as the Summit website and on Springboard. So I would like to again thank our presenters and all of our participants for joining today's webinar. Thank you for your excellent questions, and we look forward to continuing to learn from each other and support each other throughout conversations on Springboard and on the CI network. So thank you again. We really appreciate all the contributions today.